animals back in the day, those were really pretty important to rip the skin off and then take bites of meat. Just lateral to those are these cuspids just on the sides. Usually you just have one, and then your molars are back here. The molars are flat. They usually have multiple roots, and they're for grinding. Here, they're like for breaking up things and then chewing it up. The secondary teeth are your permanent teeth. There's 32 of them the next time around. Same number of incisors, same number of cuspids. The only thing different is you have a bunch more molars. Some of those molars never even erupt. They never come out through the gums. So that's why many of you probably, and including myself, have had your wisdom teeth, which are your rear molars, taken out because they never came up. But and then sometimes they're kind of growing sideways or giving people trouble, so you get them taken out. I had, when I was getting out of the Navy, I was doing surgery there at Bethesda, and I went down to the dental guys and I said, listen, I'm getting out of the Navy in a couple of weeks. Would you take my wisdom teeth out? They said, yeah, sure, doc, sit down. And they looked at them, and I came back a few days later, and they put me out and took my 4 wisdom teeth out, which hurt pretty bad for a day or two, but it wasn't all that bad, actually. But I got them all out before I got out because it was on Uncle Sam's dime. The other story I would tell you, which is off the subject, but it's another story that I tell so that I make you aware of things that I think are really important to people. When I was a kid, right back there, I had a mole, and it was a birthmark. That's what some people would call it. Some people call it a nevus or something. There's a brown spot that was about that big around. And the really ugly thing about it was it had about 4 hairs growing out of it. They were really long. And I'll remember, I never could forget going to like summer camp, and you had to go in the pool every day. And kids would point at it and, just say terrible things about this brown spot. And so I would go home and tell my dad. And of course, Dad was in the Navy, so I'd go to Navy doctors, and they'd say, oh yeah, it's nothing to worry about. It's just a little birthmark. Just a birthmark. And I wanted to say, okay, but can't you just take it off? It's ugly, and I hate it. And the other kids kid me about it and so forth. Of course, they said, no, it's not necessary. And I was getting out of the Navy, and I walked up to the plastic surgeon's office. In addition to going to the oral surgeon's office, I went to the plastic surgeon's office. I said, listen, buddy. And I'd been operating with these plastic surgeons for 7 years there. And I said, listen, I've got a spot on my back that has bugged me my entire life. I was 31 years old at the time. I said, would you please take it off? He said, yeah, sure, just jump up on the table. And I did, and he numbed it up, and he took it off, and it took about 30 minutes, and then there's kind of a Z thing back there where they pull all the skin together to close it up. And it's a little bit of a scar, but nothing to speak of. And I can't tell you how much better that made me feel. And from that point on, I didn't mind going swimming. I didn't mind taking my shirt off if I needed to for some reason. And the point I would make, and this is a little life lesson that has nothing to do with what we're studying. But if a kid ever comes in and says, I've got this spot, get it taken off for them. It's just such a big deal. Kids, life is so hard as a kid anyway. If you've got something that's out of the ordinary and the other kids can kid them about it, and you can fix it in 10 minutes by just numbing it up and zipping it off or whatever, for God's sakes, do it. And I will thank you forever. And they will too. They will love you forever because it's just so overwhelming psychologically for kids, and it was for me. All right, back to the subject. That was just I'm just going to start preaching and doing the callback thing, and but I didn't. Yes, ma'am.
I just wanted to clarify, so that's each side, so that's actually 8 incisors in your whole mouth, is that correct? Because it says
That's
8
correct.
on each side, upper and lower, so there would be, it's
Right.
that number to, okay, just clarify.
Yeah, there's 2 incisors on either side. Those are the ones in front. One, 2, and then a cuspid, third one.
So that's
and then-
per side, okay.
Yeah,
got it.
per side,
Yeah, it says-
top and bottom.
No, I don't.
So here's what they look like. Here's 1, 2 cuspids. I mean, 1, 2 incisors, and then a cuspid, just one cuspid on either side. And then your premolars back, and your premolars and your molars back here.
And that third molar, that's considered, that's the wisdom tooth?
Yeah.
Yeah,
Get
I don't
those-
know what's smart about it, but
It smarts when they're coming in wrong,
Yeah.
that's for sure.
this is the picture I was telling you about, which I never really thought about it, because you probably never thought about it either. But this is a child who died, obviously, and this is their skull. No, this is a living child. But the point being, a lot of these are still baby teeth up here. And you notice that the adult teeth are already there. They've already formed down here in the jaw, and they're just waiting to come in. So I just figured they started growing once the first one came out, then the next one started growing. But no, it doesn't work that way at all. They're all there from the beginning, and they just have to mature and grow and come up to the surface before they come out as your as your permanent teeth. Isn't that freaky looking?
Yeah.
Did you ever think about that before? No, I know. I wanted to teach you something today, and I did. Yeah.
So my husband has some like extra teeth. So like in his x-rays, like he's 36, on his x-rays you still see like
Yeah.
these extra set of like, he has like partial set of like teeth that are like.
I have this one tooth. That right there. My cuspid is twisted. And the reason it's twisted is because I had an extra tooth come into the roof of my mouth. And I had it taken out. It was the worst experience of my life. When I was like 10 years old, they took that extra tooth out, which then allowed the rest of my teeth to not be too terribly crooked. I wore a little retainer for a while, but never did have braces. Yes?
So after the teeth move out of that area, it fills in with bone?
Yeah, yeah. And a lot of times these wisdom teeth are just sitting back there. They're just still under the skin. They don't ever hatch, so to speak. I guess you call that erupt. Yes.
Is it easier to break the mandible with those teeth in there?
No, I don't think so.
Okay.
Yeah. So mastication is called chewing, and the whole idea of chewing is to move things around on your occlusal surfaces. Occlusal surfaces means the part that touches when you bite down. We have several muscles of mastication that we chew with, and the muscles of mastication are innervated by what cranial nerve? No.
Glossopharyngeal?
No.
Facial?
Facial? Yeah.
Yeah, by the trigeminal nerve.
Oh, yeah.
The trigeminal nerve, remember, is the one that brings sensation from your whole face, but it also has a muscular branch that goes down and gets your muscles of mastication. Made you think, made you think.
Uh-huh.
Okay,
That's number 5, right?
Yep.
5.
Yep.
I know 7 is.
you remember we had all these movements that we learned about, like flexion and extension and rotation and supination and pronation, all that jazz. Well, you get a few more of those here in the mouth. Elevation and depression is moving your jaw up and down. Protraction is sticking it out and in. And then medial and lateral, you can move your jaw back and forth sideways. So these are just, I don't know why that's really all that important. They seem to make sense to me. But there you have them. Okay, now let's talk. We've talked about the mouth now. And the next part of the digestive tract is the pharynx. And the pharynx you remember, is the part of the GI tract that both food and air travel through. And it is divided into three parts: the nasopharynx, the oropharynx, and the laryngopharynx. And remember that food passes through the oropharynx and the laryngopharynx into the esophagus, and you really hope it doesn't go down into the trachea. And you also hope it doesn't go up into the nasopharynx, in which case you've got milk bubbling out your nose, right? But that's happened to all of you, I'm sure. Once we swallow, and I have some videos of swallowing I'll show you, if not here in lab later. The esophagus is just a hollow muscle tube, and when you push that bite of food back in the back of your throat, it just goes down about that fast, and it's out of your esophagus. So the esophagus is nothing really happens in the esophagus except it just goes through there. It conveys solid foods and liquids into the stomach. It starts off back there just behind the cricoid cartilage, which is the one that's right below the thyroid cartilage, remember? And there's a bunch of nerve fibers that go back in there, but I don't think you need to worry about them. One thing you do need to know is that the esophagus is kind of it has a constant tone to it. So the esophagus always sort of sits there in a contracted state. Now, that's kind of nice, because otherwise, if it would just sit there open, every time you took in a deep breath, some air would probably go down your esophagus. But it just maintains a little tone in the wall of the esophagus all the time, and it keeps air from going into the esophagus. Now, we can swallow air if we want to, on purpose, but normally it doesn't happen. The other thing that's important to note is that normally you don't have any air bubbles or a column of air on an X-ray in your esophagus. Okay, so if you want to see the esophagus on X-ray, you got to give the patient something to drink, some barium usually, and that will go down and fill the esophagus, and then you can take pictures of it. Okay. The histology of the esophagus is interesting. You definitely need to look at this one under the microscope over in lab. There's three layers to it. The mucosal is the front part, then the submucosa, which we've already talked about, and then the muscularis, the big layers of muscle that carry the food, push the food down. Notice that there is no serosa. Why? Because it's not in the abdomen, so it's not touching the peritoneum. So that
Adventitia?
it's covered by what we call adventitia. That's right. You like that word, don't you? Yeah, that's a good word, adventitia. So yeah, the esophagus is covered. It's just loose tissue, and that's it. The mucosa is a non-keratinized. Non-keratinized means it's not dry. You know, keratin makes your skin dry. So it's not keratinized, but it's a stratified squamous epithelium, same as in your mouth. And underneath that, there's mucosa and submucosa, a little muscularis mucosa, not very significant. There are some glands in the esophagus under the microscope. You'll see them. They're just kind of goblet cells usually, and they keep your esophagus greased up so you can swallow potato chips. And then the last layer is the muscularis externa, which is the big muscles of your esophagus, and it's intercircular and outer longitudinal, just like every other piece of your intestine. So here's a picture of the esophagus. Now it's taken from this level up here, you see, and you notice that there isn't really a lumen. It doesn't sit there open almost ever. So here's the mucosa, which winds in and out. It's all folded in together. And this is the mucosa, the non-keratinized, stratified squamous epithelium. Under that is the submucosa muscularis and the adventitia on the outside out there. And I can tell you at surgery, when we would dissect the esophagus, you didn't really dissect. You just put your fingers in there and just kind of rooted and pushed it, and you kind of peel everything away from the adventitia, and it's pretty tough. Okay. Swallowing, another name for swallowing, the fancy A&P word is called deglutition, which is swallowing. We can initiate swallowing on our own. You can decide to swallow, and you swallow. The thing is all you do is start it. You can start the swallow, and at a certain point, you can't stop it. And that's why you've probably all had the experience of things feeling like they went down a little, and then you just, you had to bring it back up, you know. But that's because once that thing has started, it's on its way, and you can't really stop it very much. It proceeds automatically. There's 3 phases of it. This is just a splitter thing. Buccal phase is your mouth phase, and your pharyngeal phase is when it pushes the food to the back of your throat, and then it starts on downstream, and it's in the esophageal phase. Once it gets in the esophageal phase, you cannot stop it. It's going to go all the way to the stomach. Here's the buccal phase. You've got this lovely bolus of food. I like to hope that's something good instead of a yellow blob like it shows there. You notice that, you remember when we swallowed before and your larynx goes up? So the larynx, which is right here, is going to go up against the epiglottis here. And then the food is going to go on down the esophagus, which is in the back.
The peanut still in the show.
This is the pharyngeal phase, when you've now got the bolus back here in the back, and you notice that the epiglottis has got this airway pretty well completely sealed off, and off it goes. And then it's into the esophageal phase, and it goes on down, and you swallow. You remember that the trachea had C-shaped cartilages like that, and we told you that the reason they have that muscularis, that trachealis muscle across there between the 2 ends of the C, are so that when you swallow a big bite of food, it can kind of bulge into the trachea for a second while it goes on down and doesn't get lodged. Eventually, here's the esophagus coming down to the diaphragm. I showed several of y'all this yesterday in the dissections of the cats. You should be able to identify where your esophagus is going through this is the hiatus. You've heard the term hiatal hernia. This is the hiatus where the esophagus goes through the hiatus of the diaphragm, and then it dumps into the stomach. I don't think this will play.
Hi, I'm Dr. DePerrier with the Bariatric Medical Institute of Texas, and today I thought I would demonstrate what it means to have a barium swallow. This is something that we often order on patients either pre-op or post-operatively, and so I thought I would demonstrate this morning. We're here with Dr. Al Thagard, who's going to help us this morning, and I'm going to let him take over.
Okay, we like to do this in the upright position. I'm going to hand you this cup of barium, hold it in your left hand,
Okay.
turn slightly to the left, and leave your right arm down at your side.
Okay?
I'm going to fluoro now, and I want you to go ahead and take 2 big swallows for me. And we'll look at the distal esophagus,
The dark stuff is
take a spot film, and we'll watch it go through and into the stomach.
right there. This is the
And I'm going to
diaphragm.
magnify this and get another view of the distal esophagus. One more swallow, please. I like to watch it passing through the esophagogastric junction and on into the stomach to make sure it flows through freely. And the last step I want to take here is to film the entire esophagus. Please go ahead and take one more swallow. And watch as the peristaltic wave carry the barium through the esophagus into the stomach.
Do I have a hiatal hernia?
You do not.
All right.
I'm now going to lay the table down. Lean back, please. And as a final step, we're going to check for gastroesophageal reflux.
He's allowing
I'm going to
himself to be
horizontal
radiated
position
here
and
for
slight in the
science.
slight amount of Trendelenburg. I'm going to have you turn to the left side, and I want you to bear down now. strain down, the Valsalva maneuver, which he's doing now, and there is no reflux.
He's not
His
pushing
stomach
any
looks
back
normal.
up. That would be reflux.
Can I breathe?
Going back
You can
up
breathe.
into
All right,
the
thanks.
And that
This is all the stomach.
is the end of the study.
And none of the barium has gotten out of the stomach and into the duodenum there on that x-ray, which is normal. Yeah,
It seemed like it got a little stopped up there where it goes through.
it does.
Does it?
There's a valve down there. I'll talk about it in just a few minutes.
Okay.
Good question. And how do I get, who's that guy right there? God, he's a YouTube star, huh? All right, what do we gotta do here?
Hi, I'm Dr. DePerrier with the Bariatric
Hit
Medical Institute of
exit.
Texas. And
Is there an exit?
What?
Is there an exit key?
Escape.
Escape key?
Oh, yeah.
Escape, yeah.
Yeah, that's probably what I ought to push, huh?
That's right, it
It says charge battery pack for stoppage. Hey Hal,
Hey,
you're out of battery.
out of battery? Why?
was this upper
Thought you'd like to know.
Would anybody like to bring a long extension cord to
upper and lower?
class every day? Because we could plug it in somewhere and run a cord to you, and then I could put the charger on it.
Sounds perfect. Do you want to bring one?
No, I was, well, I can't. I'll get one.
The dividing line.